All right, folks. Well, today actually is an interesting podcast. Not only I have two first-timers on the Healthcare Unfiltered, and if they play their cards right, they may get invited again. But I also have two brothers that both of them claims that he knows the best and the other knows nothing. So it's great. We're going to actually probably finish today's podcast with a complete family feud. I hope you still talk to each other after this podcast. We owe this introduction to Dr. Saurabh Jaha, who is a physician. He's not a physician, I'm sorry, he's a radiologist. I take that back, in the city of Philadelphia. So we are going to talk about surrogate endpoints. First, we'll do some introductions, so at least we know who are our guests. So it's Dr. Popat, so it's going to be the same doctor. So Sanjay, we'll start by you first as to who you are, what you do, and where you practice and all that good stuff.
Yeah, thanks, Chadi. I'm Sanjay Popat. I'm a medical oncologist, consultant medical oncologist at the Royal Marsden Hospital, based in London, UK, and I'm a thoracic medical oncologist specializing in thoracic malignancies. And my academic affiliation is I'm a professor of thoracic oncology at the Institute of Cancer Research, also in London.
So tell me, in the UK, like consultant, what it's, we don't use that word here. I
think the equivalent is attending. Is that right?
Okay.
That's the sort of, the top of the pyramid.
Okay. And Royal Marsden, I've heard few good things about that place. It's not too shabby.
Yeah. I think
okay.
You'd appreciate it. I think you'd appreciate it.
It's okay. And the other Dr. Popat.
Yeah, hi, Jerry. So I'm Rakesh Popat. I'm the other Popat of the family, and I'm a hematologist, hemato-oncologist, in fact, based at University College Hospital in London. I'm an associate professor at University College London, and my main interest is in multiple myeloma, and I chair the UK Myeloma Research Group.
This is really wonderful. I'm already getting intimidated by both of you, but I'm going to do my best. We wanted to talk about surrogate endpoints because there's so much. It's a polarizing topic, frankly, in the academic community. And hopefully we will emerge on the other side of this podcast less polarized and with some common understanding of steps forwards. So Sanjay, what are surrogate endpoints? For those who are listening and they're trying to understand, what do we mean by surrogate endpoints?
Well, I mean, surrogate endpoints are outcomes of clinical trials where we're experimenting on human beings, where traditionally we've used time from starting treatment to time to death or overall survival as the gold standard as to whether a drug works or not, or an intervention works. Does the intervention or a drug make people live longer? But because this takes time, we have to wait for people to die. And we're interested in getting highly effective interventions or drugs in earlier. We're looking for other endpoints or outcomes of clinical trial which might act as a surrogate or a predictor of overall survival benefit. So examples of these are things like response rates or something called progression-free survival or time to metastatic relapse. And there are multiple others, but it's another way of getting a drug approved, usually a drug we're talking about in this setting, much earlier than waiting for your cohort of patients to die, analyze the results, and then present them at a meeting, and then go through the regulatory and, importantly, reimbursement process, something that you guys in the North America don't have to worry about.
Yeah, but Sanjay, so basically there's an assumption that these surrogate endpoints you mentioned, a few examples of, correlate or translate into better survival?
Well, that's the assumption. I mean, we have to remember where this all started from. And this all started from the premise that for a drug to be useful for patients, it has to prolong their life. Now, that's a topic in itself to debate. And the premise is that a surrogate of that, whichever surrogate you choose, is an earlier way of predicting that that patient would have lived longer with that new drug or intervention compared to not. So the assumption is that the surrogate results in an overall survival advantage. However, as I'm sure we'll debate, that's not necessarily proven with many of these surrogate endpoints, and that is for very good reasons in certain circumstances. So the assumption is that it will improve overall survival, but it's not necessarily the case. I guess it's a bit like saying, how effective is a parachute at preventing one dying from leaping out of a aircraft? But that's an assumption we can debate as well.
So, Rakesh, what I heard from Sanjay in terms of surrogate endpoints in the solid tumors in general, you're talking response rates, you're talking progression-free survival, we'll go over that a little bit, and time to metastases or something like that. Well, liquid tumors are a little bit different. Myeloma is an example. It's not like you always have I guess like a mass that you're really looking at shrinkage. Tell me about the type of surrogate points in hematologic malignancies. Feel free to use myeloma as an example. And is that similar? Any other comments to what Sanjay mentioned?
Yeah, I think there's some strong parallels between medical oncology and hematology. Again, thinking about what is our overall endpoint, it is overall survival or an improvement in quality of life. So those are the two final endpoints that we want to be able to measure. And the question is, how do you do that earlier? So in hematological cancers, again, our main primary endpoint or surrogate would be progression-free survival. And the assumption is that a PFS benefit would correlate with an improvement in OS. Now, we do have other ones, and many of us will be looking at overall response rates as a marker of PFS and therefore that of overall survival. And more recently, the big debate that we've been having, Chadi, is about the use of minimal residual disease. And the advantage in liquid tumors is that we can readily measure MRD by means of a bone marrow biopsy, or indeed we're trying to now do that using peripheral blood. And the idea is that an early endpoint such as MRD might then develop as a surrogate for overall survival, but it's still not yet fully developed.
So to recap, surrogate endpoints are these, endpoints that we think they help patients.
Yeah.
But we may not be sure.
Sure.
Sanjay, is it fair to say that the interest in surrogate points came about from the success in cancer treatments, because thankfully patients don't die that fast?
Yeah, I think that's fair. And I think the other thing we have to think about is the types of drugs we're using. Our clinical trials and our measure of success is based on chemotherapy, right? Which is what we've all grown up, been educated about. But the reality is now in early 2020, that's really not what we're using most of the time, right? We're using other drugs. We're using targeted therapies, kinase inhibitors. We're using monoclonal antibodies. We're using immune checkpoint inhibitors. Rakesh is using cell therapies, right? So do these have the same kinetics of benefit? Are the traditional endpoints that we've been hankering after, which is a improvement in length of life with metastatic disease, necessarily the right marker? And things become even more complicated in the world of solid tumors when you are dealing with curable disease or radically treatable disease or resectable disease. In that setting, we've often been looking at overall survival for the primary endpoint of a trial, but actually should we be looking at earlier endpoints such as disease-free survival or event-free survival to get a highly active drug or a regime out there to patients earlier, if we don't know that it actually makes people live longer, or whether we should be withholding it until patients are in the unfortunate position of relapse with metastatic disease. And so life has become way more complicated because of the more complex, highly effective drugs that we have available. And then when you combine that with a fragmentation of the disease types that we're looking at, we now have different diseases, all within perhaps the same label of lung cancer or myeloma, but maybe extremely rare on the basis of molecular features. And if we combine new drugs with rarity of disease, often we have to think of an earlier way to measure that these drugs are effective.
Rakesh, why is there so much controversy over surrogate endpoints? Like, why, talk to people, some people never believe in it. Like, why is there so much? They're almost polarizing medical topic.
Completely. It's a very, very controversial area, and one I'm glad we're debating. So I think the biggest problem that we have, and myeloma I think is a great example to demonstrate this, is that progression-free survival or indeed overall response rate does not necessarily correlate with overall survival. And I can give you some good examples in the myeloma literature recently. So one of the trials I was involved in is something called Bellini. Bellini was a phase 3 clinical trial using a novel drug, venetoclax, which is an inhibitor to BCL2 for patients with multiple myeloma. This was a phase 3 trial, double-blind, randomized, placebo-controlled study, so a high-quality study. And essentially what we found was that the progression-free survival was superior with the experimental arm. And everyone thought, great, this drug is working very well in the combination. But the problem then came was that the overall survival was inferior with the experimental arm. Now, the reality is that even today, we still do not fully understand why the overall survival was inferior. We think that the reality was that some of the patients that did not have that genetic subgroup that was beneficial died either rapidly due to clonal evolution and tumor progression, or they died because of severe infections. We don't know. But the bottom line is that the PFS benefit was not shown out with overall survival benefit. Now, that's an example of a drug where we think would have been effective and maybe different because of molecular subgroups, such as Sanjay was just mentioning. The other problem that we're getting is the increased toxicity with drugs. So what we're seeing in some cases is an improvement in progression-free survival, but then when you then wait and see what the overall survival comes, there is no improvement. And indeed, there may well be an inferior or concern with overall survival. Now, recently, Chadi, there was the ODAC review of a drug called melflufen in multiple myeloma. Now, melflufen was granted accelerated approval by the FDA based on an improvement, although marginal, in progression-free survival for patients with relapsed refractory myeloma. What the OS survival data demonstrated was no benefit, and the FDA, in fact, raised concerns that the overall survival may be detrimental. And so this is why it's so controversial, because in some ways, PFS does show improvements in OS. Again, in myeloma, the CASTOR trial of daratumumab, Velcade, dexamethasone for patients with relapsed myeloma shows both a PFS and an overall survival benefit. And that's great. We should be using that combination. But I've just cited two examples where the converse is not true for different reasons, I should say. So this is why it's very controversial, and we still haven't quite figured out whether we can truly believe that PFS is a surrogate marker for OS.
Yeah, these are sobering a couple of studies that you actually cited, but let's step back a little bit, Sanjay, and just try to think broadly. Is there any way that you believe, and feel free to use thoracic oncology, that you can rely on overall survival always in every single trial, whether it's adjuvant or metastatic disease, to demonstrate effectiveness? Because if you want to be purist, right, you say, okay, I don't want to do any of that stuff. I want to be very pure. Do you really feel in 2022, 2023, this is doable?
Well, anybody in the field of thoracic oncology that says that overall survival has to be the primary endpoint for every single trial is living in cloud cuckoo land, right? We have, and that's a British phrase, I guess, we have, we have lifespan, in my field, which has increased in certain sectors from a median of 1 year to more than 5 years. Okay, so how are we going to really prove that an early intervention is going to improve overall survival when you've got so many post-progression therapies which come into the argument? We've got diseases which are super rare, where it's next to impossible to do randomized trials in the first place because the prevalence of the condition is incredibly rare. I mean, a good example of this, being RET positive lung cancer trials are ongoing, but are they really needed? So
I'm going to take your argument. If you cannot use overall survival, when do you use it? What you're telling me is we cannot use it all the time. I'll take that. Yeah, give me the scenarios where you must use it, and the scenarios you don't need to use it.
Yeah, so I think at this stage, I think the the thoracic world is united in saying in a stage 4 metastatic non-oncogene addicted trial, usually we're talking about frontline lung cancer, not molecularly driven trials where we're evaluating immunotherapy as the backbone, and we're either looking at different immune checkpoint inhibitors or combinations thereof. In that setting, because of the way immunotherapy works and the post-progression benefits we see, then overall survival has to be the primary endpoint. And in those settings, we've got disease which is common. You know, we can recruit to these trials. Progression is an arguable event. We don't really understand the impact of progression when it happens in immune checkpoint inhibitor therapy, and many of the benefit that you get actually occurs post-progression if we look at the trial curves. So in those settings, overall survival, I think, has to be still the primary endpoint and the preferred endpoint. And indeed, that's what the regulators and clinicians are agreed is the right way forward. But there are many other settings where that's not the case.
So Rakesh, same question. What scenarios where you as an academician and as a researcher and a clinician, you say, you know what, if I'm not seeing overall survival advantage, I'm not buying this? And which scenarios you say, I'm willing to overlook that because of X, Y, and Z?
Yeah. So in hematological cancers, the survival is far superior to the survival that Sanjay, you've just quoted in lung cancers. So particularly in multiple myeloma, where you need to wait almost 10 years to get a readout from a frontline study in terms of overall survival, it becomes incredibly challenging. So I kind of see it in terms of frontline and late relapse. If you take a patient at late relapse where there is a very limited post-progression treatments, then I think it's perfectly valid to use overall survival as your endpoint to use a drug. And that's what I would advocate, that yes, we can accept an accelerated approval on a PFS, but we must get an overall survival advantage for the late multiply relapsed disease. Now, if you move to the frontline setting, then I think that's incredibly difficult because the whole scenario is predicated upon your post-progression therapies. And as newer immunotherapies such as CAR T therapy, bispecific T-cell engagers are coming through in hematological cancers, the complete transformation of disease is being borne out. And you will start to see it's going to be more and more difficult to demonstrate that. So, and just to give you another example, recently, the Determination trial was a study that caused big news in ASCO very recently. It was a frontline trial for myeloma. Patients were randomized against an autologous stem cell transplant versus continuous ongoing treatment with RVD. Substantial improvement in PFS was seen, but at this moment in time, no improvement in overall survival. So does that mean we should stop doing a stem cell transplant, something that we've been doing for 30 years? The answer is no, we're not going to stop doing a stem cell transplant on that basis, because there was a substantial improvement in PFS and still tells us that it is a good treatment for frontline patients. And perhaps we need to follow up our patients for 15 years to get that OS benefit. So I think for the frontline setting, it's very difficult to fully think that an overall survival benefit is going to give you the full story.
And Rakesh, I mean, the other thing is, and Sanjay commented on that a little bit, but this post-progression therapy, right? I mean, most studies I'm aware of, and please correct me if I'm wrong, most studies I'm aware of, they don't really dictate what you're going to do post-progression, right? I mean, you have the randomization, and then at progression, usually treatment at the investigator's discretion. And then you end up having this like hodgepodge of things. And how do you can try to do a very statistical manipulation and be smart about it, which is, I call it usually cooking the books. But I mean, how do you can't account for that. So I don't know.
Yeah, I mean, that's the real world, right? I mean, that's what happens in the real world. And this is why this is the beauty of trials, right? People have argued on social media that you should have A followed by B versus B followed by A, right? So you're actually looking at the true sequence. That doesn't happen in real life, right? Because people fall off the perch because they get brain disease, they get sick, they get septic, they get all sorts of other complications, which means they can't get it. So, you know, we're trained on what's called the intention to treat principle, which is we start off with a group of patients and we see what happens to them regardless of the treatments that they get. And it's all about what you're optimizing in your frontline decision making, which results in the outcome thereafter. So yeah, it would be useful to get A followed by B versus B followed by A, but actually that's made up, right? That doesn't happen in real life. So actually the trials that we have actually do represent real life, because it is a hodgepodge of what people get. I can bet your bottom dollar that what your lung cancer patients are getting in your center are very different to what they're getting in my center following first line therapy. And that's all to do with the great richness and variety of what we have in medicine.
And the assumption that if you take A, you are going to get B afterwards at progression, or if you get B, you will get A after progression, is anti-real world, because you may get A and at progression, like you said, your performance test is bad, you cannot get B, and vice versa.
Yeah, I mean, and you know, we've learned this in the lung cancer world very effectively. I mean, one of the trials that folk have argued about a lot is the FLORA trial in EGFR mutant patients, where patients were treated with first-line osimertinib versus a non-third generation EGFR kinase inhibitor, and there was a huge PFS and then a large OS benefit. And criticism of the trial was that, well, look, patients in the control arm, the majority of them didn't get osimertinib thereafter. And look, that's the real life. That's the whole point of doing the trial, is that you start off with your best drug so that you live longer, right? Otherwise, the sequence, whilst it may be an academic great thing to have and investigate, in the real world may not actually occur because of these issues like reduction in performance status and in my field, molecular transformational brain metastases. So, you know, for me, you know, we have to just deal with the trial with the patients that we have, with the best treatment up front, and see what happens thereafter. You can't mandate too many things post-progression.
So it is, yeah, go ahead, Rakesh.
Yeah, Jenny, if I was going to just bring in the myeloma side, because this is a problem that we're currently facing with our reimbursement, because, and I'll give you an example. So the tourmaline study was looking at ixazomib with Revlimid and dexamethasone versus placebo Revlimid and dexamethasone, and we saw a PFS benefit, but there is currently no overall survival benefit. Now, in terms of reimbursement, what happens in the UK, and this is probably mirrored in a number of different European countries, is that reimbursement will occur when a PFS benefit is found. So that is the surrogate endpoint. And then full reimbursement or unconditional reimbursement is confirmed once the overall survival benefit has been demonstrated. Now, with this particular study, an overall survival benefit was not demonstrated. And so what we are now expecting is that this treatment will be removed from the funding pathway. However, when you look at the post-progression treatments, what you find is that more patients received an effective treatment, daratumumab, in the control arm compared to the experimental arm. And then if you look at the sister study, which was performed in China, where daratumumab was not available, an overall survival benefit is found in the same study. Now, how do you unpick all of this and go to the payer, which in the UK is NICE, to try and tease this all apart and to see if you can convince them that there may well have been an overall survival benefit that was missed because of multiple confounding factors? It's a complete hodgepodge. And I really don't know where to go on this.
Yeah. No, I mean, I think we're all in agreement that it is not practical for a variety of reasons to be that, you know, strict that I want overall survival for every single study and every single scenario. And I like Sanjay mentioned a couple of examples where he mandates that, and some example he said he's okay with it. But I want to go back before I move on to the second topic, which is quality of life as a surrogate endpoint, to an example that Sanjay gave, which is, you know, when you have these rare tumors based on molecular subtypes, right? I mean, I always joke when I was in training, lung cancer was either really small cell or non-small cell. That was really the quiz I would tell residents. And now, goodness, there's like 20 types. So, Sanjay, are you saying that for the molecularly driven tumors, you don't need a comparator arm?
No, I'm not saying that. I think it depends on the prevalence of the molecular driven tumor. So some molecular driven tumors are actually relatively common, right? EGFR mutation in Japan, 60% of what they see. In parts of Europe, 5% of what you see. 5% of a big problem, lung cancer, is still quite a large number of patients. Is it feasible to do randomized trials in frontline EGFR mutant lung cancer? Yeah. Should you do that? Yeah, definitely. Is overall survival the best endpoint? No. Progression-free survival in the first line setting, I think, is by far the best endpoint because of these issues about crossover, about long survival, as Rakesh and you've alluded to. When we start getting more and more rarer subsets, then things start becoming more problematic. So we start talking about ROS1 fusions, 1% prevalence, RET fusions, 1% prevalence. These are rare, okay? And these are aggressive tumors. And, you know, we live in a world where we have highly effective therapies in single arm studies, which have shown, you know, big response rates in excess of 70% with progression-free survivals in excess of 9 months, right? Where we know that chemotherapy would be way inferior in a putative academic scenario. So do we really need to do randomized studies? So the FDA clearly says no, right? Because it gives these drugs accelerated approval and you guys use them frontline without a problem. The European regulator is much more cautious and still regards these molecular driven subsets to ideally undergo randomized studies. So whilst they have approved ROS1 patients, they haven't approved RET patients in the frontline setting and have mandated a first-line trial. Now, is it feasible to run a first-line trial for RET positive patients? I would argue it's difficult. So, you know, Roche and we as the academic community are trying to do these, but it's certainly not straightforward. And if we do get it, we're not going to get patients from North America because they'll all have access, right? Why would you be randomizing?
Well, but even in the US, if you get accelerated approval, but by law, you must do this confirmatory study. And I think it becomes very difficult to do when you have the small fusion. So people become creative and do synthetic real-world arms and historical controls because you really, I mean, and I can make an argument, you know, look, I mean, we all want to be very pure academicians, but my God, if you have a targeted therapy with a very high response rate and you have that mutation, do you really want to be randomized to carbotaxol or whatever it is? Versus
this is really what you know what we say. You know, three of us around the table, right? If one of us had a RET fusion, right, would you want to have chemo? Would you want to have the RET inhibitor? I think each of us would want to have the RET inhibitor, right? Same thing for NTRK, right? Each of us would want to have the TRK inhibitor. So it's crazy to mandate that we want to have a randomized trial. The reason that the regulators say that they want to have it is for a start, it's not the clinicians that are demanding a randomized trial, it's the regulators that are demanding a randomized trial. And the European regulator is demanding a randomized trial because they don't know the magnitude of the clinical benefit and hence what the risk benefit ratio is. And that will obviously drive reimbursement. And so reimbursement will come into this as well, because at the moment we're having to model the PFS and OS benefits using these methods, as you say, like synthetic control arms, to try and figure out what benefit that these single arm studies are doing. But, you know, for me, I think it's crazy not to do this. But here's the catch. This is when you have a highly effective drug with big efficacy, big response rates, big progression-free survival, and a rare patient population. An example of where actually I still think we need to do randomized trials is in the KRAS G12C setting in lung cancer, which is actually relatively common, where the drugs, you know, are probably better than chemo, but they're not dynamite in the same scope of where we are with ALK and RET, etc. And, you know, there I do think we do need to have randomized trials to really just to give us a better idea on what the drugs are bringing to the equation.
I love the idea that we are, don't, one hat doesn't fit all. And I really, if there's anybody who is listening to this, hopefully there are actually, but it's really important to recognize this. Rakesh, there are others out there who would say, okay, if you cannot demonstrate overall survival, you must demonstrate that patients are feeling better, because the progression-free survival in solid tumors is completely arbitrary. 20%, 30%, you're measuring with the ruler, doing all of this. And, in hematologic malignancies, it's a little bit more difficult, frankly, because you don't always have measurable disease. We'll talk about that when we speak on the molecular thing. But tell me about this, how patients feel better. Are we doing quality of life scales? How accurate are they? Do patients really feel them? Is it us filling review of systems, which is nonsense? I mean, tell me about that.
Yeah, I think this is an area which is completely underserved, and we ought to raise this a lot more. I mean, you take a phase 3 study, a regulation study, patients will fill in the standard QL questionnaires, the EORTC, the questionnaires are the standard that we use. And you get the results at the end, and they're always a secondary endpoint that's tucked away in a low impact journal afterwards. And typically every QL that I've seen, they're often quite similar. And you said they're trying to work out, well, actually, if there's an improvement in overall response rate, an improvement in progression-free survival, shouldn't the patient be feeling better? And that's not the case. Often in the ones that I've seen, they overlap each other. I haven't actually seen much in the way of a detriment in terms of QOL in the studies that I've seen. So I think there's a couple of things. The first thing is I don't think we do them well enough. The second thing is that I don't think that the questionnaires that we have are sensitive enough. I think the QOL questionnaires are quite a blunt tool, and they don't fully reflect the improvements in quality of life and symptomatology that our patients have. And number three, I think QOL should be a much higher endpoint than a late secondary endpoint. I would love to see a study where we had a co-primary endpoint of progression-free survival and QOL with your OS as your key secondary endpoint. But I've never seen that.
I mean, Sanjay, the reason I bring this quality of life issue, not obviously it's important. We all know the importance of this. We don't need to sell that part. But progression-free survival, it's really this 20% and 30%. Somebody had a conference in Hawaii and they were sipping wine and 20% seems reasonable. It's completely arbitrary. So that's why it gets so much bad rap, because who the heck cares about 20% or 22%? And that's why folks appropriately demand, look, these percentages are arbitrary. We need to make sure that patients are feeling better.
Yeah, I agree. PFS is a very arbitrary judgment, right? I mean, who determines whether 21% is bad and 19% is good, right? So it's complete madness. And in some tumors, it's so difficult to measure measurable disease anyway that a few millimeters here and there, there goes your progression event, right?
Right.
So then the regulators have demanded we have independent radiology review because the investigators are all biased because we know what the patient's on, and so you go around this merry circle of doing whatever's required. So quality of life, I think, is really important. But as Rakesh has said, the fundamental challenge that we have is that the instruments that we use, God bless the URTC because it's come up with these great validated tools, are just not discriminatory enough for us to make enough sense out of them. I've seen so many trials where you've got what looks like a pretty toxic drug. We know that the drug is toxic because we've used it in phase 1, phase 2, and here it is in phase 3. And you look at the quality of life and you're thinking, actually, that's not reflecting, what my patient experience has been so far, and is not bringing out the salient features of the problems of the drug. And that's not a problem of the trial design. It's a problem of the instruments that we have. Good example is like CTCAE, right? This is the standard instruments that we use to determine the toxicities of a study. who determines whether the adverse event that we're reporting is treatment related or not? I mean, it's a judgment call, right, which is made between the sponsor and the investigator that's reporting that. And are our CTC-AE terms actually clinically relevant these days when we're using non-chemotherapy drugs? I mean, for IO, they're probably not. And certainly for a lot of the targeted therapies, I would definitely say that they're not. So we definitely need better metrics to quantify the subjective improvement or not that patients feel. And there's a variety of ways that might be done. But the measures that we have at the moment are not really up to the standards that we'd like.
So then the main issue, Rakesh, is now we're obviously not too happy with progression-free survival. We realize that quality of life is good, but we don't measure it very well for a variety of reasons that you both outlined. And we understand that overall survival is the gold standard, but we cannot really rely on it all the time. So now we're not even doing this. We're going to go on the molecular level. So people are going to be even more skeptical. Like you're telling me because you detect a clone that I can't even see anywhere on a slide or wherever it is, that's going to be enough. I mean, you could imagine that the field would be like, wait a minute here. I mean, that you're taking it to the extreme. Take us through the molecular part, because analogous in solid tumors, I think an example to that would be, could be cell-free DNA or whatever you want to call it. But in the hematologic malignancies world, you can understand why folks are very skeptical about minimal residual disease, no?
Yeah. I mean, this is an area that we've been trying to develop and bring forward. What I would say is that minimal residual disease has been consistently shown to correlate with overall survival. And we can see that in myeloma, CLL, and ALL. So it's been demonstrated, I think, fairly broadly across hematological malignancies, particularly the liquid ones, that minimal residual disease, either by bone marrow biopsy testing or peripheral blood testing, does correlate with overall survival. Now, there are some problems with it. The first is the technique that you're using, because you're right, we're talking about molecular testing now. Okay, so we're not now talking about a PFS. You've got to make sure that your technique is high sensitivity enough, and the higher the level of sensitivity, the more robustly you will correlate with overall survival. The second problem you have is the quality of the samples, and this is a major problem we've got. Is that if you've got a poor quality sample, then you're not going to get a clear MRD result, and then what do you do with it? The third point is the timing of your sample. When is the optimal time to take your MRD time point, and is a single MRD analysis adequate as a surrogate marker of overall survival? And I would argue that you need multiple time points, and you need to demonstrate sustained MRD negativity. So in the myeloma world, interestingly, we're now talking about how do we assess cure. Okay, we've got PFSs of 10 years plus in the frontline setting. We think that overall survival is going to be in excess of 15 years. How do we define a cure? And that now there's this debate of saying, well, actually, can we have a surrogate marker, molecular surrogate marker of a cure? And can that definition be sustained MRD negativity at 10 to the -6 for 2 years? As a surrogate marker of cure? I don't know. It's very, very debatable and very, very skeptical if you can call that a cure. But that's kind of where we're heading, because what we've got to try and work out is where are these new field of cellular therapies going to take us to? Because the PFS is going to be astoundingly long. So yes, MRD is important, but another caveat I must say with molecular therapies is that we know across hematological cancers is that there are major sampling issues that I alluded to. And so the strength of MRD testing is made greater by the use of cross-sectional imaging.
But the issue with MRD, if I may, two things I'd like you to comment on. One, nobody is arguing that they are prognostic. Yeah. No one. We know that if you're MRD positive, you are going to do worse than MRD negative disease. But the argument is twofold. Number one, if you're MRD positive, does it make a difference if you treat at the time of MRD positivity versus waiting until clinical relapse? To my knowledge, we don't know. So I'd like you to comment on that. And the second thing, if we really assume that MRD negativity correlates with improved survival, what we risk is overtreatment. Then what you're going to see is a lot of people are going to get treated until MRD negativity, and the fear of that, toxicity, cost, and maybe you are treating folks that may have not even relapsed for 10 years.
Yeah. Okay, so these are all very good points. And I think the second bit that you need to bring into this is the clinical risk of the disease. And again, we are very polarized in our views on this. Now, some doctors you'll speak to will say, actually, MRD negativity is the be-all and end-all, and you should treat for until MRD negativity, albeit with that increased risk of expense and toxicities. The second factor is, how about your risk, your biological risk? Now, typically we correlate that by genetic risk in hematological cancers, either by FISH, gene expression profiling, or PCR. And that's really, I think, what you're getting at, Charlie. The question is that if you have a good risk disease or standard risk disease by genetics, do you really need to achieve that MRD negativity? Or will your patient still do well with a low level of MRD positivity? And I think that data is still controversial. And that also speaks to the point about what should you do if you relapse from MRD negativity, because you're absolutely right. If you step in as soon as the patient flips from MRD negative to MRD pos, then they haven't progressed in terms of criteria. And if you're intervening, of course, your PFS is going to be better, because you only had a small molecular signal in terms of disease. So you're going to demonstrate an improvement in PFS. But crucially, is that going to detect an improvement in overall survival? And I don't know whether that's going to be the case. There are studies actually looking at this. And in fact, I was talking to my colleague in Norway who's running this study. And the major problem he's facing is that he's going to have to wait 10 years before he gets a result. And again, it's a real problem, and we don't know. But I think with high-risk disease, perhaps you should treat MRD negativity. And with high-risk disease, perhaps you should treat a flip from MRD neg to pos, knowing that you are going to inflict more toxic disease and more expensive drugs, but you know that that patient's going to do very badly because they have high-risk biological disease.
It's an area that could be studied for high-risk disease in a randomized fashion, I presume, but I don't know if that's being done right now or not. It is?
No, it is. It is actually. So as I said, it's interesting because different groups are doing completely different things. The French group in myeloma have decided that MRD is the ultimate answer, and patients are being treated according to MRD, irrespective of biological risk. The UK has taken a slightly different approach, and we're merging both together, so that standard risk and high risk disease are being treated differently according to their MRD status, and we'll wait and see what the results show.
Sanjay, 10 years ago, probably if we talk about MRD in solid tumors, would be laughed at. Not the case anymore. I mean, I think it's still behind hematologic malignancies. We all recognize that. But draw some analogies between what Rakesh said to the molecular. What are you guys doing in solid tumors on the molecular front? And do you really see this is evolving into where this becomes an endpoint, achieving MRD negativity? You see it monitoring. There's a lot happening in the liquid biopsy front and all of that.
There's a lot going on. And it's mainly around cell-free DNA or ctDNA using different technologies. And I'm going to divide the answer into the metastatic setting and in the curative resected setting, because we're using them differently. So the first thing is that they're not very well established, and still we're lacking a lot of data apart from certain scenarios. So in the metastatic setting, I think what's very clear is that some patients who shed their ctDNA do worse than those that don't shed ctDNA, and patients who clear their ctDNA with systemic therapy do better than patients that don't shed their ctDNA. So the big question is, can we consolidate those patients who have not cleared their ctDNA with traditional therapy with more treatment. So you start them on treatment A, assuming they're shedding in the first place. You see what their ctDNA does, and then at particular time point, if they've not cleared it and they're still shedding, then you get randomized to more intensive consolidation or not. And there's a few academic studies ongoing in the US looking at this. I think this is really the major point where we're going to take things further in the metastatic setting, because we have our established paradigms of we know what drug to use for which biomarker, but the key issue is who needs more and more drugs, right? We're talking about just adding more and more to the cocktail. There'll be some patients who do very well anyway. We can't easily pick them out according to the molecular status that Rakesh has talked about in myeloma, that we can do in at least thoracic malignancies. We have some biomarkers, but they're a bit imperfect. And so ctDNA clearance stands out as one of the potential to do this, but it's problematic because what defines what level of ctDNA you look at, right? One manufacturer's ctDNA assay will be different in terms of sensitivity to another, and what are we looking at? Are we looking at fusions or SNVs? We're looking at overall variant allele fraction, etc. So there are lots of technological issues which bear this to mind. The area where I think we're probably going to be using it more is in the post-resection setting. So this is a patient who's had their cancer resected, and we would usually be giving them chemotherapy after resection or not, depending on their standard risk profile based on TNM scores, usually, sometimes biological scores. And then the key issue is, in an uncertain patient, does MRD positivity or not define whether you need adjuvant chemotherapy or adjuvant immunotherapy or adjuvant TKI. So that's one area. And we've seen a really positive result in colon cancer at ASCO this year, where MRD positivity did determine whether you benefited from adjuvant chemo or not. I think that's ready for prime time. But other diseases at the moment aren't. Lung, urothelial cancers, not necessarily quite there with MRD. And I think we need to evaluate that further. The other setting is you're following up a patient, they've had their curative resection, they've had their adjuvant chemotherapy, and then you're following them up with MRD, and then they flip from being MRD negative to MRD positive, but yet you've got nothing that you can see on a CT scan or a PET scan. What do you do in that scenario? So, you may argue that MRD has picked up your relapse 6 to 9 months earlier than it would have been picked up by traditional imaging criteria, because you can't see a lump at that point. But what are you going to do about that? We don't really have any data which say that treating on the basis of flipping negative to positive MRD actually does anything other than just panics the patient for 9 months more than they would have done, right? So I think MRD is exciting. I'm delighted to see what Rakesh and his colleagues are up to, but it's work in progress, and I think we, as the academic community, need to build on that data a lot more.
One of the biggest challenges I see in evaluating MRD and trying to conduct trials in both sides, I'm curious about your thoughts on this, is anytime you want to design a study to treat, let's say, early at MRD positivity versus late at the time of clinical relapse, there must be an assumption that you are going to use the same therapy. I mean, frankly, if you're going to use different treatment, it's not going to work. The problem is that you don't have that time to clinical relapse, and you don't know what patients, if you're going to take you 2 years to treat, gosh, it could be very different therapy. So in the studies of MRD positivities, how are you guys in those two disciplines, heme malignancies and solid tumors, accounting for this? Is this being studied, early therapy versus delayed therapy? I think it's a reasonable question, and I think it's a very ethical question to ask. Early therapy versus delayed therapy at the time of MRD positivity, but you must use the same treatment in both arms.
So in the solid tumor world, I think that's less of an issue than it may be in the hematological world, because the timeframes are not necessarily that long, right? We're usually talking about 6-9 months, okay. And that's the sort of median timeframe between flipping from negative to positive to then finding measurable disease on a scan, right? We're not talking about 2 years, 5 years, okay. Right? So in that sort of setting, your probability of patient deteriorating and not receiving the planned therapy that you had at time of MRD's flip is pretty minimal, right? You will lose some because of attrition for all the usual reasons, right, that we talked about, but it's not a big loss. We don't have huge numbers of trials looking at this. There are a few in the lung world. We had 2 great AstraZeneca-sponsored studies, Mermaid 1 and 2, but the design was not really accounting for where we are currently with adjuvant IO, and so they've been paused, and I hope they get redesigned and relaunched in a better manner. But we are lacking a lot of data in this scenario. I'll just come back, right, to say our gynae colleagues were looking at CA125 for many years, right, after curative surgery. And there's a pivotal study many years ago at ASCO presidential session many years ago, which showed that treating on CA125 relapse versus measurable disease made no difference in overall survival. So again, the question is, you can prove that, but what's your endpoint going to be? Is it going to be PFS? Is it going to be OS? What's going to be meaningful? And there's going to be a lot of difficulties in teasing apart this data.
How about in myeloma, Rakesh?
Yeah, so I think it depends on how you design your trial, because there are 2 different trials that are looking at this, one in the Norwegian group and one in the US, and they're doing things differently. So the Norwegian group are doing the purest route, which is you take your patient, you give them initial treatment, they achieve MRD negativity, you wait until you flip to MRD positivity, and then you either treat that patient or you randomize not to treat that patient. Now, if you're going to do it that way around, it's impossible to give the patient the same treatment, because so much time has elapsed at that time that anything could happen. In the US study, they're not starting at the very beginning. They're simply saying, right, take a patient who is MRD neg, and then let's take them onto the study when they flip into MRD positivity. Now, if you do it that way around, then yes, you can have the same treatment, because you're taking patients either when they enter at MRD positivity or whether they enter at relapse. But the whole problem with that type of approach is that you can't control what happened at the front end. So you've got a very heterogeneous population being treated in different ways, different biologies, who are then treated in a homogeneous way with homogeneous treatment at relapse. So I think both of them are problematic, and I'm not sure either of them are going to answer the question. So yeah, it's a bit of a minefield trying to work this out. It reminds me actually of some older data that's been published, which is treating in myeloma upon either biochemical progression or a clinical relapse. And what that data shows is that if you treat a biochemical progression, your outcomes are better than a clinical relapse. But I think that's an inherently biased way of doing it. And of course, that's going to show you a benefit. So we have to get away from that approach.
It depends how you define the benefit, because you get the lead time bias suddenly between, if you treat based on a blood test, it's very difficult. So I want to try to come up just to, as we finish this, and just like few, pearls or common grounds, because I don't think we're going to resolve the controversies of surrogate endpoints. So I want to try to come up with maybe like few items in each discipline that should not be controversial, where, look, this is how it is. These are not controversial. And then finish with the controversial areas which hopefully will be resolved in the next couple of years. Although, frankly, if everything is resolved, I can't do podcasts. So I'd like to still keep doing this. So far, you're even, by the way. In terms of, I'm not keeping score who's smarter than the other. But certainly, Rakesh, you excel in thoracic oncology, and Sanjay excels in heme malignancies. So Sanjay, can we come up in solid tumors, with few things where you really feel that folks should stop arguing about?
Yeah, I think metastatic immunotherapy-based trials, overall survival is the gold standard, and I don't think that should really change. And I think pretty much everybody agrees with that. Even the regulators and the drug companies agree with that, right? So I don't think that's really arguable. In the sort of oncogene addicted space, in diseases where we have these, progression-free survival has been accepted by the regulator as appropriate for a drug approval. And I think for most drug genetic aberration combinations where you've got high efficacy, I think that's absolutely fine. And the more prevalent the genotype, the more I would argue that you do need to have a comparable arm, just to make it certain that we are achieving a benefit. And then we get to the more controversial areas, and the more controversial areas are, I think, in the curable setting, because in the curable setting in solid tumors, we've really been basing overall survival as our gold standard. And in recent years, with the advent of adjuvant immunotherapy, or in lung cancer, preoperative chemoimmunotherapy, we're using event-free survival or disease-free survival as a surrogate endpoint. Is that really a gold standard? I think that's an area of ongoing discussion. The regulators seem to be approving it, but I think it depends a lot on the magnitude of benefit that we're seeing.
Rakesh?
Yeah, so I don't think there's ever going to be alignment in the world of myeloma, So I think, Chadi, there's no fear of you never ending your podcast if you invite myeloma speakers on board. I mean, my view on this really has to be that for patients with an expected brief or shortened overall survival, then overall survival should still be the key endpoint that we're looking at. So patients with relapsed refractory disease or patients with ultra high risk disease, overall survival is an endpoint which is achievable and should be the primary goal. However, if you move earlier in the disease pathway for standard risk and newly diagnosed patients, then I think I don't think that's going to be possible. And PFS continues to be the endpoint for the approval and the usage of drugs in that setting. I think the big major controversies continue to be around molecular endpoints such as MRD, which we've discussed. It's still not accepted, despite some of the work that we've been doing. And I think that we run the risk with cellular therapies to really hamper the approval of cellular therapies, which are so effective in terms of achieving MRD negativity.
I think maybe I'll throw a couple of things to you as a provocative thoughts and have you reflect on that. Let's see if we can agree to this. How about if I tell you I don't think response rate should be a surrogate endpoint? Would that be something you would be in favor of, or you would say response rate must be still used as a surrogate endpoint?
So in myeloma, I would agree that response rate is no longer indicative. I think we have better endpoints such as MRD than a response rate now.
So in the solid tumor world, I think it sort of depends on the prevalence of your disease area, right? So if you have something that's super rare, like TRAC fusions, or even rarer NRG1 fusions, response rate.
Sanjay, can you define rare? I'm trying rare, what is rare?
Yeah, I think we're talking about, a genotype which occurs at 0.5% or less of the population that we are looking at. So these are really rare occurrences, a case that you're going to see once every 6 months. Okay, that sort of rare case, right? So, response is part of the package because it's the response rate, the duration of response, and the progression-free survival in a single-arm study. I think that will define what you're talking about, because we're never going to be able to do a randomized study in this super rare population. They just won't, the patients won't exist, right, to be able to do this.
Okay. How about if I tell you another point? So we talk about response rate. How about if I tell you that progression-free survival should never be used as a surrogate endpoint, ever, unless accompanied by quality of life measurements?
I think that's laudable, but not realistic, right? So we have to do quality of life measurements, but we just spent 15 minutes trashing them, right? Saying that they were just rubbish, right? So yeah, we can do quality of life assessments, but we need to do better quality of life assessments than the tools that we currently have. Yeah, I agree that PFS has to be accompanied by QOL, but just because your QOL isn't any better doesn't necessarily mean that you can ignore the PFS. I mean, if your PFS hazard ratio is 0.5, yeah, I'll buy that, even if the QOL isn't better.
I'll have to tell you, it's actually a topic I've been trying to tape a podcast on, and I'm not going to lie, I can't find the right guest. This is true story.
It's a really tough one. QOL is a really tough one to get right.
Yeah, because it's just, to your point, it's just like you want to bring somebody who's an expert in the area, but also, and it's there's a lot of folks who claim that, but I haven't found the right person for quality of life. So what should we end up with? Any parting comments? I mean, I think this was very lively and a lot of things to think about. If I put on my listener hat, what I've learned is we cannot always depend on overall survival. We have to have an open mind based on the disease and the situation. Number two is, look, I mean, the future is heading into molecular monitoring, whether we like it or not. This is what the future is. And frankly, 10 years ago, much of the advances we have today would have been a dream 10 years ago. So, but I want to make sure each of you get an opportunity to address anything I forgot to ask and any additional comments. So Rakesh, why don't you start first?
Yeah, thanks. So I think it's about putting the patient in front of you and remembering what we're doing and what we're after. So the key things is that we want to make our patient feel better and to live longer. And any surrogate endpoint that we're going to pursue, we have to be confident that you're going to achieve those. So for me, it's about making sure we're not doing any harm with toxic drugs, which may impair the overall survival of the patient as the key thing, and making sure that we are only using the most effective treatments, which are likely to do well in terms of quality of life and in terms of how long that the patient may live for.
Sanjay?
Yeah, I think that's absolutely correct. We have to do all of that, and we have to use the technology that we have to work out who needs the treatment, who needs additional treatment, and who can get away with standard treatment. I think in solid tumors we look a lot over our shoulder to what these guys in the heme world are doing, because a lot of their technology with MRD, etc., is going to come through within the solid tumor field, and so we have to pick up their mistakes and try and get them right, and make sure that we can implement the science into the way it should be. But I think the take-home message is that there's no one optimal endpoint for everything. There's no Lord of the Rings, right, which is power over everything. We've got to use a different endpoint for a different clinical scenario to get the right treatment for our patients.
Heme malignancy, folks, don't do any mistakes. What kind of rubbish is he saying? What is that?
Yeah, well, we're perfect.
Yeah, perfect. Well, I've enjoyed this a lot. Every time I tape a podcast like this, I feel I'm learning a lot from you. I couldn't be really thankful enough for you taking time and of your schedule. We're taping this actually when it's a little bit in the evening in the UK, and it's early it's midday in Chicago. And I have to tell you that one of my dreams have been always to learn how to speak in a British accent, because I would sound just very sophisticated, and like whatever you say just sounds authoritative immediately.
Come and spend 3 months with me, Chaddy.
I would love to. I would love to. Well, it's a pleasure. Thank you so much for spending time on your Sunday, and look forward to seeing you in person at some point. Rakesh, are you going to be at ASH?
Yeah, I'll be at ASH.
I'm going to see you at ASH, and we'll do a selfie, and we'll make sure we send it to Saurabh Jeha. He claims to be a physician, but we all know he's just a radiologist.
We all know he's a slightly dodgy physician.
Why do you guys still talk to him? Like he left the UK. We need to trash him a little bit.
I know. We're bonded for life. Having spent 6 years in medical school with this guy, sharing flats, we're now bonded for life.
It's so nice to see you.
Great.
Awesome.
Fantastic. Thanks, Chaddy.